Hello, in this video I'll be talking about the differences between tamoxifen and the aromatase inhibitors. Before I do, I'd love to invite you to go to Yerbba.com where you can get your personalized report and learn more about these options with respect to your specific case. I'd also love to invite you to subscribe to our channel. We always put out new content, so there's always something new to watch. We've had a lot of questions about the pros and cons of tamoxifen and the aromatase inhibitors, and I think it's worthwhile to talk first, why do we use these drugs at all? And then what are the key differences between the classes of drug, the selective estrogen receptor modulators, which tamoxifen belongs to, and the aromatase inhibitors, which many of you are taking. Both of these medications are a form of endocrine therapy. They work through the hormonal system in the body. Sometimes you might hear this called endocrine therapy. We don't call it hormone therapy though, because that makes many people think of hormone replacement therapy. So either hormonal therapy or endocrine therapy. We give these medications only to people whose tumors have the estrogen and or progesterone receptors. Check out our video on estrogen receptors and progesterone receptors if that would be helpful. Tamoxifen is given to people who are premenopausal, people who still have functioning ovaries, people whose ovaries are making estrogen. And that's because of how it works. I'll talk about that more in a moment. The aromatase inhibitors are only given to people who have no more ovarian function, whether they went through menopause because they reached a certain age, whether they have had their ovaries removed for one or more reasons. They only work in people whose ovaries no longer work or never worked. One way that we might be able to do that with a patient is to suppress the ovaries with injections. I know a lot of you are on medications that suppress the ovaries and put them asleep, make them dormant temporarily. So if you're postmenopausal because of medications you're getting, because they've been removed, or because it's your time to go through menopause, aromatase inhibitors are an option. They are not an option if you have functioning ovaries. If you're curious about which type of endocrine therapy or hormonal therapy might be offered to you, you can go to Yerbba.com and get your personalized report. Your Yerbba report takes all the information from your medical records. This is from your records related to breast cancer. It's not going back to your childhood records. And this is different from your medical portal. The Yerbba report is very different from your patient portal because it compiles all that information in one easy-to-use report and then cross-references all the characteristics of you and the tumor and the treatments you've had, and presents you with all of your treatment options, including the pros and cons, things you might expect to hear about as you go from the various medical specialists. Tamoxifen works not by lowering estrogen in the body. In fact, in some people on tamoxifen, estrogen levels actually go up a little bit in response to the estrogen receptors being blocked. I'm going to hold up my hand to show you the estrogen receptor. So let's imagine this is in the tumor and it's an estrogen receptor. Estrogen comes along and sits in that receptor, estrogen made by your body. If I put something in there, however, I'm going to put my tablet in there. If I put something in there, now the estrogen can't go in there. It's a estrogen receptor modulator. So now the estrogen is bouncing around in your body, but it's still in your body. So tamoxifen does not lower estrogen if you're pre or postmenopausal. It just blocks the receptors. Aromatase inhibitors work a completely different way. You have all this estrogen in your body made from other parts of your body, and aromatase inhibitors block the production of estrogen. These are estrogen molecules, and I'm going to make them go away because you're on an aromatase inhibitor. Aromatase inhibitors decrease the production of estrogen by an enzyme in your body called an aromatase. Aromatase, any word ending in ASE, is an enzyme, and aromatase inhibitors inhibit the aromatase enzyme. Now your body can't make estrogen from in other parts of the tissue of the body. Tissues that make estrogen even after menopause are fat, breast tissue, and the adrenal glands. So our bodies, even after the ovaries are removed or are dormant, still make estrogen, and the aromatase inhibitors block that production of estrogen. Sometimes that's called peripheral tissues. It blocks the production of estrogen from peripheral tissues. So that explains, I think, why tamoxifen can only be used in pre or postmenopausal women, and the aromatase only in people with no functioning ovaries, however the ovaries get to be that way. So we've talked about your ovaries and how the medications worked. What about you as a person? So a couple things. One is if you're on a medicine like tamoxifen when your cancer is diagnosed, we are not going to recommend that you go back on tamoxifen after that cancer is treated. So we want to be really careful not to continue to expose you to a treatment that worked well but stopped working or didn't work well enough. So if you had a first cancer and were on tamoxifen and you have a new cancer, also hormone receptor positive, we won't put you back on that because the tumor grew despite the tamoxifen. Other things that go into play, I've talked about menopausal status already. Another thing is how you tolerate these medications. I'm putting this right up front because your preferences matter. Your preferences matter and how you feel matters. We're trying to improve your quality of life and the length of your life, and if you feel terrible on one drug or the other, it doesn't really matter what the data show. The data is in your body. You are the data, in other words. What are other things that might matter? People who have very thin bones will benefit from tamoxifen, and tamoxifen strengthens the bone in postmenopausal people. So that's amazing. It looks enough like estrogen to the bone that it actually fosters bone health. So in people who have very low bone mineral density and where we don't want to do anything to impair their bone mineral density, we might recommend tamoxifen. Tamoxifen is also protective to the heart. By lowering bad cholesterol, it actually probably protects the heart. And the aromatase inhibitors have a slight increase in the risk of cardiac events. So that's a reason that we might lean towards tamoxifen. Most of the time, other medical problems don't inhibit our selection of the best breast cancer therapy. We have ways of reducing your risk of heart disease. We have ways of lowering your cholesterol, even without medications. We have ways of helping your bones, even without medications. So we try not to let bone health and cardiovascular health change which medicine we choose. We really want to give you the best anti-cancer therapy. So what helps us know which drug to use, and why do most doctors favor the aromatase inhibitors in postmenopausal women for certain? We know these drugs are being used more often. And if you can't tolerate the aromatase inhibitors, what does the data suggest about tamoxifen? We know that tamoxifen is a very powerful tool in the treatment of breast cancer. Tamoxifen, if we could just get every person in the world with hormone receptor positive breast cancer on tamoxifen, we would save so many more lives than by adding newer drugs or changing medications to those that have been developed more recently. Tamoxifen is a very powerful tool. So why would we choose the aromatase inhibitors? A study was conducted many years ago that compared tamoxifen to an aromatase inhibitor, to the combination of both, and the group that received aromatase inhibitors had a better outcome. When I talk about outcomes, I'm talking about disease-free survival, no recurrences, recurrence in the other breast, and long-term survival. The aromatase inhibitors had a slight edge over tamoxifen and over the combination of the two put together. So that study, which is abbreviated the ATAC trial, showed that the aromatase inhibitors have a benefit over tamoxifen, and that includes in the other breast. And in fact, much of the benefit was in reducing the risk of a new cancer in the other breast. So this has led over the years to the aromatase inhibitor being the preferred choice in the treatment of breast cancer. Again, though, tamoxifen is a very powerful drug. We know that all aromatase inhibitors are equally effective in treating breast cancer. We know that 10 years is more effective than 5 of tamoxifen, and we know that we can switch people from an aromatase inhibitor to tamoxifen or tamoxifen to an aromatase inhibitor, and it doesn't matter which order. So the decisions about which are based on how you feel, functioning of the ovaries, your other medical problems, how long you're going to be on treatment overall. Are you going to be on for 5 years? Are you going to be on for 10 years, or somewhere between 5 and 10? A lot of decisions go into this, and we have a lot of videos about the aromatase inhibitors, how we compare the aromatase inhibitors, each aromatase inhibitor, tamoxifen, side effects of all of these, and long-term effects, as well as how long symptoms will last if you stop the medications. I hope this is helpful. This is really meant to be sort of a endocrine therapy 101. We love hearing from you. Put a comment or question below. We get back to you within 1 to 2 weeks, just as soon as we can. And as always, thank you for watching. We'll see you next time.